The subject of this talk is actually physeal injuries. Physeal injuries are common, and they are much more common than we believe. Some 30% of children's fractures involve the physis, and the distal radius represents some 25 to 40% of the cases. Boys are much more affected than girls, and 54% of fractures are Salter-Harris 2. As regards the physis and modes of bone growth, few words about this entity. Physeal growth ceases in boys at the age of 20 and in girls at the age of 18. Axial growth, as we all know, is through the physis via an endochondral ossification. And circumferential growth is via membranous ossification, subperiosteal bone deposition. The hormonal influence of bone growth are testosterone, thyroxine, estrogen, and so many mechanical and genetic factors are included. Reminding myself and us about the anatomy of the physis, the well-known 4 layers, the germinal cartilage zone, zone of resting cartilage, the proliferation layer or the zone of columnization, and the cell hypertrophy, disintegration, and calcification by invasion of metaphyseal vessels. And the last one is the deposition of osteoid and forming the secondary spongiosa. Physeal injuries, the mode of injury is usually rotation or shear, low velocity in most cases, and sometimes maybe occult. Rapid healing occur in less than 3 weeks, so we have to diagnose early and treat early. As for the classification, there are so many classifications actually. The first was in 1998, and the last one is 1981 by Ogden. It's very, very difficult, as you are going to see now, and the most valid of all these classifications are Salter-Harris with Ranks version. Just to have a look on the Ogden classification, some 9 groups with 20 subtypes. I think nobody will remember all these types or these subtypes. As I said before, the Salter-Harris with Ranks version are the commonest classification, and to a great extent is the easiest classification. We speak about Robert Salter and Mercer Rank in few minutes. Robert Salter was born in Canada in 1924 and passed away in 2010. He pioneered the development of children's orthopedic surgery in Canada and I think all over the world. And he was the surgeon-in-chief hospital for sick children in Toronto, Ontario, Canada. The second hero is Mercer Rank. He was born in 1933 in London and passed away in 2003. He was graduated from England. He wrote many books on children's fractures. He was the staff of Hospital for Sick Children in Canada. This is the Salter-Harris classification that we are going to explain in details. It's quite sufficient for any orthopedic surgeon, general or pediatric orthopedic surgeon, to treat well this type of injury. Type 1 Salter-Harris classification is fracture through the junction between the metaphysis and physis. And the physis is not affected. No fracture line occur in this area. So it is just separation of the epiphysis and physis from the metaphysis. This is type 1. And this is the most easy type to treat. Example, traumatic slipping of the upper femoral epiphysis. Salter-Harris type 2, there is also a fracture at the metaphysio-physeal junction, but with a small triangular fragment from the physis that is separated. Again, no injury of the physis itself. Best example is fracture of the distal end of the radius, slipping of the distal radial epiphysis. It's also, again, easy to treat and easy to give good results without complications. Now we come to the most difficult cases. Type 3 Salter-Harris. There is a fracture in the epiphysis itself that reaches the articular cartilage, and part also of the physis is broken and displaced. Again, this is the best example. As you see, fracture passing through the epiphysis and part of the physis. Type 4, much more difficult one, fracture with a big fragment from the distal end of the metaphysis, and also part of the physis. Also, the fracture is reaching the articular cartilage. Type 5, there is compression of the physis. Compression that lead to destruction of the cells at this area with arrest of growth of that bone. Actually, this is very difficult also because sometimes we didn't see it in the X-ray and we anticipate it. So we have to do check X-rays to see whether this has happened or not. This is the best example. You see, this is an injury of the distal end of the tibia and nothing at all in the X-ray. After 3 months, you see arrest of growth with consequent growth of the fibula in a normal way, and the tibia will stop growing. Type 6, which is added by Mercer-Rang in 1969, he called a Physeal injury. Actually, one of the ligaments, whether the medial or lateral, will pull part of the physis, of the epiphysis, and of the metaphysis sometimes. So this is a Physeal injury. We come now to the principles of management of physeal injuries. First, diagnosis. Second, goals, reduction with avoidance of the growth plate arrest if possible. And now the actual treatment, operative or non-operative. Starting by the diagnosis. Before we speak about the diagnosis, I mean the clinical diagnosis, we should recall the words of Bob Bright. Today, many of our clinical diagnosis skills have atrophied from underuse. Nobody is examining children, just do an X-ray or do CT or do something without touching the child. I think this is completely wrong, because we should have an index of suspicion first, and then good clinical examination. And the two important signs are local tenderness over the physis with swelling. Sometimes the child didn't say anything about the mechanism of injury, also nor his father. We have to suspect, should have an index of suspicion, and we should examine the child. Of course, we should do an X-ray after that. But the usual modes of doing the plain radiography is like this. We should center the X-ray tube over the location of the physis. We should have two views, AP and strict lateral view of the injured and normal side. For comparison, we should do both in the same film or in everyone in one film. Sometimes if the things are not going in the right way, we do oblique views, 45 degrees oblique views. And again, also we should, in some cases, do stress films to differentiate ligamentous injuries from physeal injuries in children. Although it is not that common, but we have to do it. And the last choice is MRI and CT, which may be resorted to in difficult cases. This is a stress view showing injury of the physis. In the plain X-ray, there was nothing. Just abduction led to opening of the physis at this area, and it's not a ligamentous injury, it is actually a physeal injury. As for the principles of management, the first aid treatment, starting by all suspected physeal injuries should be splinted, iced, and elevated, while the various diagnostic studies are being performed. The second important item is clarification. We should clarify before treatment, we should clarify to the family that injury to the growth plate had occurred, and future growth at this location may be altered. He should know that before starting treatment. The goals of treatment first is to reduce the fracture, with very important issue, which is avoidance of growth plate injury. It is already injured, but we can do injury by excessive manipulation or uncontrolled manipulation. No question that fewer attempts at reduction under heavy sedation or anesthetic are the least traumatic. And again, it's advisable not to do more than 2 trials. Reduction as usual in any fracture by distraction, then manipulation, and well-molded cast with 3-point pressure to induce tension on the periosteal hinge. This is an example of displaced distal radial epiphysis, and this is the position of the hand in flexion and adduction with molding of the cast via 3-point pressure. You see in the X-ray the reduction is perfect. Now we come to the time of manipulation. Better to do it few hours after injury if possible, within 3 days, and never after 5 days, because after 5 days, as I said before, healing starts rapidly, and if there is excessive manipulation, you may injure the growth plate more. This is the opinion of Bright. Salter-Harris 1 and 2, the stable and easy types, after 5 days with less than 1/3 displacement and less than 15 degrees angulation, is allowed to heal in a cast without manipulation and checked after 2 years by X-ray. If no remodeling, we can do angulation osteotomy, which is the least traumatic than to do repeated manipulation in these cases. Immobilization time is half the time for the bone in the same region to heal. For lower limb physeal injuries, no weight bearing is advisable in the injured lower limb. As for follow-up, Salter-Harris 1 and 2, closed reduction. Patient is X-rayed every 5 days for 2 weeks. If displaced, we do immediate open reduction, least traumatic. Better to be sure than to be sorry. Salter-Harris 3 and 4, even undisplaced, open reduction and internal fixation, we should be also atraumatic. In type 3, we resect the periosteum around the devices 1 centimeter on either side of the growth plate. In type 4, if the metaphyseal fracture is not very large, it can be removed to improve visualization of the physis and the assurance of accurate reduction of the physeal cartilage plate. One important thing is during internal fixation, transfixing wires should not cross the plate at any point, lest growth arrest occur. Screws, we can do over drilling, but no too much compression of this area. This is the excision of the distal, small distal fragment, and this is the wires applied. In Salter Harris 3 and 4, follow-up is by check every 3 months to 6 months and then 1 year. We should do these X-rays for follow-up of the case to see whether something bad had happened or not. May be extended to 2 years to check growth disturbance. Salter Harris 5 and 6, only check X-rays 3, 6, and 12 months post-injury. Some sketches of the internal fixation of apophyseal injury, Salter Harris 3, Salter Harris 4, how to apply the wires, to apply the screws. Sometimes we need to have plates. Again, apophyseal injuries in the lower limb. See? Complications of physeal injuries, acceleration is rarely a problem. It occurs only in the first 6 months to 1 year, and in immature skeleton, stapling or 8-plate may be used, and in mature skeleton, shortening if more than 1 inch. Complications of physeal injuries, physeal closure. Physeal closure is complete only in type 5. It is infrequent. It is of paramount importance in limb segments with two bones, the forearm and leg, because one bone will grow and the other will stop growing. Treatment in young patients, epiphysiodesis of the other bone. Limb physeal callotasis and chondrodiastasis, like Gamal Husni, Debastiani, Steen has done. Sequential lengthening if we need to do in hurry, but I do prefer using the X-fix. The second complication is physeal closure, whether it is partial or central. Partial physeal closure in Salter Harris 3, 4, and 6, or due to infection, burns, implants. Types, Bright described 3 types of physeal closure. Peripheral, leading to angulation. Central, leading to tenting. Mixed, showing both. This is the sketch of the peripheral growth arrest, cross-section. Central growth arrest with tenting. Treatment of physeal closure, partial physeal closure, is by excision of a bar, resection and interposition of fat, or osteotomy in late cases. And this is the central physeal closure with tenting. The treatment is to do a window and remove the top of the pyramid at this area. And after that, I think the growth will be much more better than if we leave it like that. Sometimes you need again to do an osteotomy with external fixator. Kamal Husni again, we will ask his help. To summarize, Physeal injuries are common. Classification aids management algorithms. Anatomical reduction for Salter-Harris injuries 3 and 4 is essential. Remodeling reduces the need for aggressive manipulation. Early recognition of potential growth arrest is essential. Thank you very much for your kind attention.
Thank you so much, our dear Professor Khamis El-Deeb, for this very interesting talk about a very common topic, Physeal injuries. شكرا جزيلا أستاذنا الفاضل، طبعا شرف كبير لنا أن حضرتك الافتتاح الجميل للكورس ده يا فندم.
شكرا يا سعادة البيه، وأنا قاعد بسمع جمال هيقول إيه؟
اتفضل دكتور جمال بيه. نبدأ الأول أسئلة، لو في أسئلة يا فندم للدكتور خميس بيه.
اتفضل.
طيب هو احنا معانا بعض الأسئلة يا فندم. هو في واحد بيسأل is it important to tell parents that there will be a physeal derangement of any type of Salter injuries?
I say yes.
Yes, of course.
Especially in Salter-Harris 3, 4, 5, and 6.
Yeah.
We should tell the patient's family that a problem may occur. We are trying to avoid it, but it may occur. Otherwise, the patient's father will ask you, why didn't tell me from the start?
Yeah. We have another question.
It's not needed actually, but in 3, 4, 5, and 6, we should tell him that a problem may occur in the future. We are trying to avoid it.
تمام فندم. معانا another question من اخونا الحبيب دكتور عدنان المفلح من اليمن، هو من الناس اللي حاضره معانا كل الكورس بصراحه. بيسال سعادتك على السايز اوف سكرو، التايب اوف سكرو، وهل هو حضرتك fully or partially threaded؟
احنا متفقين ان السكرو ما يبقاش يعني ما يبقاش حكايه فولي ثريدد دي. لو انا عاوز اعمل كومبريشن بس احنا ما بنحبش كومبريشن كتير في الحته دي. فاي دو بليف ذات reduction and ordinary screw fixation will be sufficient. Sometimes when we try to do compression, it will be too much more, and it will induce at the site of the fracture growth arrest with stenting later on. So I do prefer to put fully threaded screw after good reduction. The size, I think the ordinary screw. We don't, of course, put lag screws, canceller screws, or something like that. Ordinary screws.
Sir, we have two questions about type 5 epiphyseal injury. The first question is the sure diagnosis of type 5.
Just to do X-ray after 2-3 months. Sometimes we didn't see anything in the X-ray. That's why we should put the patient in a cast, but do follow up to check whether the arrest had happened or not.
Yes.
Because it's in the plain X-ray, the first time you didn't see anything. As I showed you the plain X-ray of the child, and after 3 months, no growth at all. So this is a sure diagnosis of the case, and we should in double bone segments, we should do epiphysiodesis of the other bone. Otherwise, there will be some disruption of the radioulnar or the tibiofibular joints.
Yes. The second question, sir, about type 5 is anything can be done for type 5 to avoid epiphyseal growth arrest?
We didn't diagnose it except after it happened. if this problem has happened, nothing in the X-ray appear. So we put the patient in a cast and follow by check X-ray. we will not, we can't avoid anything. If it had happened, the X-ray will be free from the start. But after that, when the growth stopped, there will be no physis present, and then we treat accordingly.
Yes. Another question, sir, from Dr. Physeal. What about crossing the physis with smooth pens?
It's not like it.
Yes.
It's not like it. Despite sometimes we may need to do it. But if we did do it, we can remove this wire after 3 weeks, 4 weeks.
Yes.
Just to have starting union in the area.
Yes. I'm sorry, you have more questions, Professor Khamis. Another question from Dr. Saad Al-Ashri. How long do we follow kids with Salter-Harris type 2 distal radius and those with lateral condyle fracture operated with manipulation under anesthesia and KYS? I think you have mentioned this, sir, in your talk.
Yes, I said that. 3, 6, 12. 3, 12.
Yes, sir. Another question, if late presentation with angulation and displacement, would we try reducing it? If not, and what's the solution?
I think Kamal Hosni is the main man interested in these things. I can't say anything except after Gamal gives his lecture about this.
Yes. The last question, sir, in fixation of type 4 can be done with key wires?
I like actually to put in type 4 screws.
Yes.
In the fragment that is there, right? And I like to put screw in the metaphyseal segment and wires in the epiphysis itself. Because
Thank you so much, sir. احنا تعبنا حضرتك بالاسئله يا دكتور خميس، معلش احنا اسفين يعني يا فندم.
حاجه خالص لا.
ربنا يكرم سعادتك يا فندم.